You have a right to publicly owned information, and the Access to Information Act gives you that power. I know you have enough questions about how government are run or not run, so let me show you how it works. Say mosquito spraying going on in your community, your children asthmatic and you want to know what chemicals are in it. Or what about that Auditor General report on a public official getting twice his salary with no proper approval? Is your taxes and you want to know if they paid it back? First, do some basic searching to see what is already on government websites. If you don't see what you're looking for, make a formal ATI request by completing the application form on the ATI site or sending a letter or email. And remember, you don't have to say why you need it. It is your right to know. Make sure you send your request to the right agency, and once they confirm receipt, they get 30 calendar days to provide the information. A maximum of 60 if extra time is needed. Yes, I know you want access to everything, but sensitive documents are protected from the public for up to 20 years. For example, documents that would expose a citizen's personal privacy, or those dealing with cabinet discussions, the Governor General's office, or information on the investigative activities of the security forces. Any public officer who tries to destroy or hide any official document can be sanctioned. And if you're having difficulties, the ATI unit will help. So, what if the chemicals in the mosquito spray are toxic? What if the agency did not even try to get back the money they paid out? Call or email your MP. Share the concern, because as your elected representative, they can represent your questions to the government ministers in the House. Remember, it is the job of parliamentarians to monitor and hold the government to account on your behalf. Is not every country give citizens this kind of power, you know? And at 20 years we have this law, and we barely use it. So access information and mind your business, Jamaica. Visit jampja.org today to see what information we access to make it easier for you to hold the government to account. Let's do our job to make Jamaica land we love, Jamaica land we own, and Jamaica land we run well. A message from the Jamaica Accountability Meter Portal, funded by the European Union in partnership with the Private Sector Organization of Jamaica.
A new story is being written for all Jamaicans. The Ministry of Economic Growth and Job Creation is on a mission to transform lives. From increasing access to potable water, providing secure homes for the most vulnerable, and helping you own a piece of the rock, we're revitalizing communities and preserving our environment. We're making an impact. See the difference. Feel the difference. Building a better Jamaica for you and me.
You can feel it. Make JC.
Zoom in on the nutrition facts. It in at the table on the side or the back. You fi check out the servings, just do the maths. Not taking too much, finger below the facts. Zoom in on the nutrition facts. It in at the table on the side or the back. Take note of the sodium, the sugars and the fats. 5% or less in the on the right track. You fi zoom in on the nutrition facts. It in at the table on the side or the back. Vitamins, minerals and vitamin 2, 20% and more that good for you. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. You fi zoom in. Check the nutrition facts. Less sugar, less salt intake and less fat. You fi zoom in.
A message from the Ministry of Health and Wellness, Jamaica Moves, the Heart Foundation of Jamaica, the National Health Fund, and JAP.
Continue to give us life, give us strength with all your mercies that you have to offer. We ask for your guidance in these proceedings as we continue to do the work of those we serve. We invite your presence, your guidance. Lord, there are times when we may fall short of your glory and your expectations. At these times, we ask for your merciful forgiveness. We continue to ask you to protect us, being your servants. These we ask in your blessed name. Amen.
Amen. Thank you, Senator Gill. Do we have any apologies for absence, Madam Clerk? No apologies for absence. Very well. Today, it is intended... I'm sorry. Madam?
Sorry, Ms. Wilkins will not be able to make it today.
Very well, okay. Miss Wilkins is absent today, but the LRD is still well represented, correct, Ms. Rodden? I believe so. All right, so today, thank you so much. Today we have on the agenda presentation by the Ministry of Health and Wellness, and but before that, our agenda asks us to confirm the minutes. I know members would only have received the minutes yesterday, and I crave your indulgence to allow us to take the minutes at our next sitting. I don't want us to sort of get in the habit of deferring, but I also do want members to have had a chance to properly read the minutes. I did receive some guidance from our parliamentary staff recently about this practice of us doing confirmation of minutes in our public meetings. And the advice I was given is that the best practice across parliaments, particularly Commonwealth parliaments, is that those are usually done prior to the opening up of the meeting in the public domain. It sort of makes sense because the minutes are a bit of minutiae and a little tedious, difficult for the public to connect to them, and really a part of our due diligence to ensure that our record keeping is accurate. So I'd ask members simply to review the 2 minutes, one quite short and a longer one, and we would then confirm those on the next occasion along with the minutes that come from this committee prior to engaging in our substantive work. Very well. If there are no objections, then we will go ahead with that. I don't have a lot of remarks to make this morning. Suffice it to say, we have had the benefit of hearing submissions from the Legal Reform Department. We've heard submissions from the Ministry of Labour and Social Security, and they've promised to return to give us an even more in-depth presentation. We have heard from Statin, very useful information about the data surrounding the elderly population, the senior citizens our senior citizens. Much of that I know members have vigorously interrogated, and I'm hoping that members are beginning to sort of form and frame their minds to the kinds of proposals that we need to come up with, that we've been guided on from the submissions we have heard so far. Today, the Ministry of Health and Wellness is with us, and it is the intention to hear in our next meeting that more fulsome presentation from the Ministry of Labour and Social Security, and thereafter the MDAs who have made submissions and who we have asked to make submissions, I think we would complete those hearings. It therefore would be next in line for us to begin to hear the submissions from the wider public and other stakeholders than the MDAs who we are now hearing from. It is my fervent hope and wish that we can get through those next month. And so I did ask the clerk to propose some dates to the members so we can grab some dates, because we are competing with the same space and same team, same support services as other committees. So if members would kindly indicate their availability, I believe an email was sent, so we can sort of set those dates in place to get through the work before this committee. So that said, can we invite the team from the Ministry of Health and Wellness to join us? Welcome, Senators Morris and Fraser-Binns. I gather you have joined us online. Thank you, my colleagues.
Thank you, Chairman. Good morning. Good morning, everyone. Madam Chair, my name.
All right, are we full and settled? Good morning and welcome. Ministry of Health and Wellness is well represented this morning. I'm going to ask the PS to introduce himself and introduce the team. Just to let you know, I know the chambers look scanty, but this is a hybrid meeting. And so Senators Morris and Fraser-Binns, Longmore and Sinclair have joined us online. And Senator Gale and I are holding up the walls in the chambers. So we have a pretty full committee membership present today. So with that said, Mr. Green, can I ask you to do the necessaries and to introduce your team as well?
I'm Errol Green.
Just before you do that, for those not familiar, you have to touch the mic to the left, I think it is, and then I have another button here I press to allow the mic to go on. It's a little complicated.
Thank you. I'm Errol Green, the Permanent Secretary in the Ministry of Health and Wellness. To my right is Mr. Howard Lynch. He is the Senior Policy Director in the ministry. To my left, Dr. Karen Webster-Carr. She's acting as the Chief Medical Officer at the moment. Behind me, to my left, is Dr. Sean Moncrief. He is the head of standards and regulations. To my further left is Mr. Everton Anderson. He is the head of the National Health Fund, and he will introduce the two members of his team.
Yes, morning. So we have Ms. Grayson Johnson. She is the Senior Director for Pharmacy Services at the NHF. And Mr. Ainsley Jones, he is the Senior Director for Individual Benefits, ICT, and Research at the NHF.
Thank you very much. Mr. Green, we're all yours, so how you want to do this? We'll leave it up to you. The committee is pretty fluid. We have been operating in a sort of fluid way with members asking questions. The only thing I would ask is members just to indicate, the members online to just indicate their hands. We're monitoring the online platform so that I can ensure that the monitoring of the meeting captures who is speaking. All right? So over to you, PS.
Thank you very much. I'll first ask Dr. Webster Carr to speak. She is acting in the position of the CMO. Then I'll ask Mr. Lynch and then Dr. Moncrief. Mr. Anderson.
I'm very, very pleased to welcome Dr. Webster Carr, and she knows why. I just want to indicate to members, Senator Gale would have his hard copy in the chamber, but there was a submission sent by the Ministry of Health and Wellness, and members would have received that in their email yesterday, Madam Clerk? Yes. So if you could just double check if you don't have it, just check your email. It should have been sent to you yesterday. Dr. Webster Carr.
Thank you, Chair. So we have the first question. The question was the issues, challenges, health, social, and others, any others faced by elderly with whom the ministry and its agencies interact that need to be addressed in legislation, as well as gaps that exist which require legislative solution. According to the Mental Health and Homeless Task Force of 2017, 157 persons discharged from hospital across the island, but still on the wards, the majority of which were over 60 years, with a duration of a few months to as much as 10 years. The incidences of abuse, neglect, and exploitation and discriminatory practices meted out to the elderly at times result in new or worsening health challenges, loss of property and investments, and feelings of hopelessness. These incidents can occur in their own homes and communities, nursing home, as well as healthcare facilities. Some of our facilities are not designed or orientated to cater to the needs of the older persons, whether it's physical, visual, or hearing impairments. There are also lack of access to special services. Some bedridden and homebound clients are unable to access care. So in summary, the issues include difficulty in accessing government services and benefits, in the absence of birth registration, inadequate transportation services in the community, increasing number of homebound clients requiring home visits, vulnerable elderly clients are in need of trained caregivers, and inadequate health insurance and social protection. So that, in summary, for question one.
Before you move on, Dr. Webster Carr, Madam Clerk, you're monitoring on the platform, yes? Question for you. When elderly folk are, I keep dancing between the senior citizens and elderly folk, but I think I'm more speaking about the elderly in my question. How does our health sector and our health professionals meet the elderly who have suffered abuse? Are they meeting them in the clinics? Are they meeting them in the hospitals, home visits? Where do you encounter that? And when the health services encounter that, what is the duty that the health services have? What duties do they engage?
Thank you. So we don't meet many persons who report abuse. Many of the data are anecdotal. Among persons attending to the elderly, the majority of the abuses are reported to be financial abuse. So we tend not to interact as much, but when we interact, it is a legal matter and will be referred as needed.
So you refer those matters to the police? Is that how the health services treats with it?
That is what would happen or should happen.
Okay. Thank you. Please continue.
Thank you. Are there any existing policies?
I'm so sorry. One moment, Dr. Webster. Dr. Longmore, I apologize. Go ahead.
No worries. I just had put up my hand. Thank you so much, and welcome to all members of the Ministry of Health team. I'm very sorry that I'm not able to be in chambers this morning to welcome you personally. I just wanted to find out what is the working definition that the Ministry, for our clarity, what is the working definition that the Ministry of Health uses as elderly? I just want us to be clear on that, please.
So the elderly is defined as 60 years and older.
Okay, so it's 60 years and older across the board, across the Ministry of Health and Wellness.
Correct.
All right, thank you. Thank you.
There was another question I had. You mentioned about the difficulty that they have accessing government services, particularly in circumstances where there's no birth registration. How does that impact that population in terms of accessing health services? You need your birth certificate when you go to the clinic? How does that play out?
So that mainly affects their access to drugs from NHF and JADEF. So getting care within the public health system, you're not required, that's not required. They will access care freely.
Okay, and I guess Mr. Anderson will address that in due course.
So he will tell you how they overcome that particular.
Thank you. Mm-hmm. Go ahead.
Thank you, Madam Chair. Thank you, Pierre. So, sorry, I will deal with question 2, which speaks to any existing policies within the ministry, specifically geared towards the elderly, or provisions in any laws that are implemented by the ministry which provide protection to the elderly. So, in terms of our response to the question, there are about 4 pieces of legislation: the Public Health Act, Mental Health Act, Nursing Homes Regulation Act and Regulations, as well as the NHF Act that addresses issues. So there's no specific legislation in the MOH that targets the elderly. But there are others across the board: Poor Relief, Disabilities, Maintenance Act, as well, that would address matters related to the elderly. But in terms of policy, recently the ministry took to cabinet the primary healthcare reform policy, which was approved. And within that policy, there's an expectation that what we call a life cycle approach would be applied in the primary care delivery. Within that life cycle approach, it moves from maybe pre-birth, childhood, teenage, male, female, and then elderly. So programs would be structured within the primary care program along the life cycle approach. And some of the specifics, we would have health promotion and prevention programs tailored to older adults, which would include the elderly, treatment services that address multiple morbidity and the geriatric syndromes, as well as provision of palliative care services, right, as well. And
Mr. Lynch, could you just explain what that means?
The palliative part?
My prayer is that there are our citizens listening to our YouTube feed. So just give them an idea what that means.
Sorry, which one should I? The palliative part? All right. So I'm not really a physician, but there's a stage where we try to manage the pain. We can't do much more in terms of treatment, but we manage, pain-related issues, and we manage them. We can't cure them, so we manage the issues that ail the individual to make their life more bearable with their health condition.
Thank you so much.
All right. So the other specific would be the strengthening of coordination and continuity between all levels of care. Primary, which would be our health center setting, secondary and tertiary, which would be our hospital setting. So what we anticipate within our primary healthcare reform, that patients will move smoothly through each levels of care based on their need and the intensity of the treatment that they require. So, as we said, life cycle, so for each group in the cycle, programs would be designed for them. We will also expand community-based healthcare services to support vulnerable elderly patients. And another key feature of the primary care reform is a kind of an integration where health will seek to integrate with other social services to ensure that patients receive the necessary interventions from any state program that exists. So it's more than just the health care that is anticipated. So it's the whole individual that the primary care will be focusing on. And I'm stressing that it's life cycle, so it's not just the elderly. It's for all groups within that life stage or life cycle.
I'm looking at you interestingly because I recently had a conversation with a former public servant, civil servant,
yes.
Who shared with me the need to have a place in communities where people could go, and particularly vulnerable people could go, to find out what services exist, where they exist, and how to access them. There's a lot of services and government programs that are available to the population, and a lot of the population sometimes not aware of what is accessible and what is available.
Yes.
So I'm particularly interested in that kind of coordination in your primary health care reform. How is that anticipated to work? Because you're going to have the Labor and Social Security Services, you're going to have the Ministry of Local Government Services through the municipal corporation, I suspect. Is that going to really be a sort of coordinated, or does health say, okay, do you know that this is available, go over there and access that? How is that really going to work?
All right, in response to you, Chairman, we're building it out as we're conceptualizing the build-out, but the ministry has taken some intervention so far because we have a new division created in the ministry that is to enhance social work within the healthcare system in terms of what is required of them. And we also intend to build out an information system that allows the continuity. So part of that expectation is that with this information flow, improved social work capabilities within the healthcare system, then it will enhance what is expected out of primary healthcare. Maybe what I should have said is that the matter was just recently passed by Cabinet. The project managers just come on board, so we are building out the project over time. So it's not going to happen immediately, the intervention, but conceptually, this is what we expect to happen out of the program once we have fully implemented it.
I thank you for that, and I'm so pleased to hear about it, because oftentimes the population is a little distant from what the ministries are doing. You don't kind of hear, and people complain. They go to the, they access the services, and they may not have a pleasant engagement, and they sort of brush everything about the health sector that way. So I'm very pleased. It sounds like a sort of visionary, long-term, sustainable approach where we are looking at taking some of the pressure off the hospitals and going into the communities and dealing with primary health care at that level. So I am particularly pleased to hear that. Thank you.
And as Pace just had reminded me, we are contemplating...
Pull your mic up a little.
Oh, sorry. We're contemplating as well expanding the roles of some of our health providers to allow more community-type interventions. So we'll go out in some instances to the patients, will take the care to them, and through the information system connect them back into the formal health facility. Let me say health facility because the rollout of our ICT is in both primary and secondary care, and we're piloting that now with the HSSP project funded by the IDB, where we have a network of 3 hospitals and supporting health centers for these hospitals. So we'll be testing the model in those settings.
I have a question for you about that. When the elder citizen engages at the public health clinics, or through whatever community program is available to them, is there a register that is sort of kept? How do you know? Is that part of their health record in the public system? So you've logged them. They've come in for this particular reason. You're looking at preventative care and that kind of thing. If you never see them again, how does the health service reach them? Or do you attempt to reach them?
The follow-up will be done through the community health aides.
Good. Okay,
community
health aides
would reach out into the community.
Okay. I believe Senator Longmore has a question.
Thank you. And I appreciate hearing the rollout of this program. It seems to be quite likened to what exists presently with the community approach for mental health care. What I'm wondering is there synergy with this program and the integration, from multiple mental health task force that has been engaged? There has been the emphasis for inclusion and a very significant focus on mental health care integration at the primary level. My question is the plans that you are now indicating as a pilot, one, is that in synergy with the existing community-based mental health care efforts? Two, is it something separate from that? And three, as in those, what has been known for decades, because we've been doing this community approach for mental health care. This was introduced from back in the 60s, etc., coming up, developed, is a model for the world, best practices, etc. But we here are recognizing the deficit in some of the necessary support mechanisms at that community level for care. Is there plans afoot, learning from what has happened in mental health to ensure that we don't have those shortfalls when this community approach for primary care is taken?
That one maybe. So I'll defer to Dr. Webster on that one. I turn it off.
So,
okay, thank you.
Thank you, Senator Longmore. So, yes, it was considered in the preparation of the plans, the concept, the mental health, and it will be an integrated approach. For mental health, there has been developed a micro plan, which includes many of what you mentioned. So the integrated, using the lessons learned, the number of task forces that have already gone before. So the answer is yes, and we're building out as we speak.
Okay, all right, thank you.
Can I just piggyback on that question from Senator Longmore? This committee, for the purpose of the team at the Ministry of Health, This committee arose out of a private member's motion in the Senate. And the mandate of this committee is really to make proposals for a law, a comprehensive law addressing the elderly population, elderly needs. So we've heard from Statin, we've heard from the Ministry of Labor and Social Security. We've looked at the legal landscape, courtesy of the Legal Reform Department, across other jurisdictions. But one of the things that we learned when Ministry of Labor came was the inadequacy of the Maintenance Act in dealing with elderly citizens who are not being cared for and who don't have any means and resources to care for themselves. And that conversation also included a conversation about the Guardianship Act. Certainly, from my own perspective, I can tell you it's not necessarily a quick process, even if you do have family who is interested in supporting elderly citizens. So my question coming from what Senator Longmore was saying, in the community mental health programs, or it's really not necessarily mental health alone, when the health services meet these individuals, what's the step from there to them getting help? What does the health services do, and what's the obligation of the health services, other than just treating illness or treating the physical health of the person? When you see that, what happens?
Yes, thank you. That is a difficult one, and this is why some persons having been discharged from hospital are remain in hospital for 10 years, because family members don't comfort them, won't accept them. So this is a big problem for us. In probably around COVID time, we tried to, with the municipalities, for them to move into some of the infirmaries. That had limited success, and so it continues to be a concern.
So Dr. Webster-Carr, when you talk about the 157 persons discharged, that's a 2017 figure, right? Currently, as we speak, our hospital system is holding, well, they're no longer patients because they've been discharged. What amount of persons would you say are residing in the hospital system because their families have abandoned them?
Senator, I don't have a number now, but based on what I've heard is what happened during COVID, etc., the numbers, it just created space for other persons. So the numbers are similar. Some parishes have done better than others in reducing that. But
pull your mic a little closer for me.
Okay, we still have. I think PS wants to help me in this question.
Okay. And after PS comments, I'll ask Senator Fraser-Binns to ask her question. PS?
I know that the number is very high. In fact, in Trelawney, there is a ward comprising, I think, almost 40 persons that used to be housed at the Cornwall Regional Hospital that they had to move. The only place they could accommodate them was in Trelawney. In Spanish Town, there's also a ward at the infirmary of about another 40 persons that would have been at the Spanish Town Hospital, notwithstanding the number of social cases at the Spanish Town Hospital, even as we speak, is over 20. And we're looking at a situation where we don't have enough beds in the hospital to accommodate persons who should be admitted, and they take up a lot of space. At the KPH, I think the last count I got was 32 at Kingston Public Hospital. Social
I reached 132
right.
so far.
So the number is significant.
Taking up hospital beds in the national services,
right,
not available to people who are actually sick because
right,
families have just not.
Right, right. And not only that, but the cost for care in the hospital will be far more significant than it would be were they in an infirmary. Mm-hmm. We try to work with the local authorities to see how best we can trim down the numbers, but as fast as you take 2 out, 3 more comes in.
Yes, yes. P.S. Let me ask Senator Fraser Binns, whose hand was raised.
Thank you, Chairman, and good morning to everyone. Chairman, I just want to follow up on the issue raised by Senator Longmore, particularly about the abandoned elderly in the hospitals. And I wanted to find out, I know that you'll forgive me because I can't recall your name, but you tried to give us some figures, but I wondered whether you have an exact percentage as to the increase in the number of abandoned elderly in our hospitals. And secondly, in working with the community health workers, if you have been able to ascertain the reasons why families have abandoned, neglected these persons, and what steps, if any. I mean, I know earlier in the discussion when we met with the ministry or the Attorney General's office, they shared with us the provisions in the law. But I want to know what social intervention steps have been taken or have been explored by the ministry in ascertaining, well, in trying to get some support for these persons. And finally, we haven't yet dealt with it, but I'm going to have to leave early, Madam Chair. I want to talk a little bit about what I perceive from a very peripheral, unscientific level, just by talking to persons. But certainly I'd like to hear from the Ministry of Health as to what information they have in terms of the number of elderly persons who are now being impacted by, whether it is Alzheimer's, dementia. But from my interaction with a number of persons, it is my view, not scientific based, just my view though, that there seems to be an increase in the number of elderly persons who are impacted by dementia, Alzheimer's, and I would like to know if that is the experience from the ministry, because certainly you'd have more scientific data to share. Thank you, Madam Chair.
Thank you, Senator Fraser Binns.
It's a very interesting question, or some very interesting questions, Senator. We at the ministry have a concern about the high level of dementia and Alzheimer's that we are seeing. The CMO minister, myself, and the team, we are looking to see what can be done to address these issues, because these issues are real, and we see them every day. I know that the Ministry of Local Government has taken some steps, because they just trained some community mental health officers who are placed in each infirmary and in the Golden Age home. They graduated, I think it was 3 or 4 weeks ago, and they are placed at the respective infirmaries and at the Golden Age home to address this very issue. But it is one that is very active in the mind of the CMO, the minister, and myself and the team at the Ministry of Health. As to the numbers of social cases in hospital, I can't give you a figure on that today, but I know it is significant because it affects our ability to care for those persons who come to seek support at the hospital treatment at the respective hospitals and they can't find a bed. Some persons have to be sitting in chairs for days, weeks even, just in order to find a hospital bed for them to be cared for. So yes, it's a concern for us. But when we look at what can be done, there's a Maintenance Act, and there's also the Poor Relief Act. In my former life, I always encouraged the inspectors of poor to utilize the Maintenance Act, because you can take people to court for abandoning your loved ones and for not looking out for them. And under the Maintenance Act, I believe you are responsible to your grandparents even to ensure that they are okay, and whatever the government have to spend in care of the elderly can be recovered if that is pursued. So we're having discussions.
Yes, I'm going to interrupt you just to share with you that when we had it was local government, yes. When we had the Ministry of Local Government here, they shared with us how the Poor Relief Act provisions work. And I don't know that there was anybody who could cite a single instance where the municipal corporation had taken any action. Yes?
That's the exact point I'm making. I was a town clerk for many years, and I've always asked the inspector of poor for Kingston and St. Andrew, how many persons have you ever taken to court to maintain their parents?
But that for us, PS, is precisely what we're concerned about, because if you've had this law in place but it has never been used, it's a sign that it's not workable. So how do we address that? And the same is true for the Maintenance Act. The difficulty with the courts is that there was no disaggregation in terms of elderly maintenance cases. Well, am I recording that correctly, Senator Gale? Or was it that we didn't have it disaggregated by gender, but there was there were no citations of any cases in relation to the elderly?
There was none.
So again, but it's not easy to bring. It's not easy to bring. And if it were easy to bring, people would bring it. So the point is, we have laws in place. They don't work. We are in this committee charged with making proposals, but those proposals need to be workable proposals and accessible proposals. I mean, if you think about it, the very concept of a municipal corporation taking a body to court, taking somebody to court in relation to an elderly person, I mean, perhaps when we were a much smaller country that sounded like it could work, I don't know, but it's just not conceivable to me that it could work. So when we meet these cases, and this is the thing that we're grappling with here, when the health services engage with them, what are you seeing? What are you doing? Is there a reporting line that needs to be mandated in law? Is there a next step or an initial step to bring it to the attention of another body who may act under a law that you see as your role in the health services? And after you answer that, I'm going to ask Senator Longmore to ask her question.
Well, I've been...
Oh, Senator Gale, I'm so sorry. Senator Longmore, if you would allow me to just... allow Senator Gale to ask his question.
Right, thanks. So
yes,
when we explored the legislation, I was trying to look for it. There may be a gap in law in terms of whose obligation it would have been to trigger that abandonment. Would it be the municipality? Certainly the elderly would have been fearful on their own to even trigger it. So whose responsibility it would have been to kind of create that catalyst? That's the first instance. But I want to go back to something in relation to the process that may lead to the abandonment. Now, when you are at the point of admission, or the intake, isn't there contact information taken on relatives for the purposes of contact tracing? So at that point in time, you may have known, you may have had data that says that this is a relative, John Brown, representing Mary Sue, who is the elderly. And at the point where they are now ready for discharge, isn't there a pursuance of that contact tracing in the first instance to seek to treat with those persons?
If I might answer, yes, there is. No one comes into the hospital without being properly registered,
right,
and information taken. What happens in a lot of cases is that persons are taken and they're just left. You try calling the numbers that they give you on the record, no one answered. Just recently, the CEO of the Spanish Town Hospital put a gentleman who wanted to go home. He owns his own house. He wasn't a ward of the state. He has his own property, owns his own house. But family members didn't want to be bothered with him. And the CEO and the social worker put him in an ambulance and took him home because he knew that he didn't have to be in the hospital. He didn't want to be in the hospital. And the family actually called on the television station to say, we don't want him, take him back. Nobody's here to look after him. What do you expect us to do? We have many instances, even at KPH that I know of, I used to be CEO there, where persons are taken to their homes and taxis, and by the next day, 2 days after that, they're back in the hospital because the relatives just do not want them. There was a case of a gentleman who was hit down by a JUTC bus, and he came from Clarendon, and he has a son living in Kingston. The relatives in Clarendon used to come and look about him, and after a while, they just forgot about him. He ended up in the hospital a second time. He died. When contact was made with his son, he said, I don't care what you want to do with him. Don't call me. Do not call me back.
That might explain the number of homelessness you see on the street. That is not really homeless.
Indeed. And when it was time for the insurance money to be paid out, then you had people coming to me
in droves,
appealing to me to help them to get a copy or issue them a copy of the death certificate so they could go collect the insurance money from JUTC. And my staff said, no, we're not going to do it. But those are things that we see every day.
Thank you, Chair.
Thank you. Senator Longmore, I'm going to have you ask your question at this time, please.
Okay, thank you, Chair. I wanted to bring to the attention also in the consideration of that we are trying to get numbers in terms of the abandoned individuals. Recognize that a significant amount are actually at the Bellevue Hospital. A little synopsis, Bellevue is coming from over 3,000 patients in the 60s, and with the advent of the community service and the community approach to treating with mental illnesses, that figure dropped down to almost just over, I think presently over 500 patients, of which approximately, I'm going on the lower side to be careful because I don't have the very specific figures, approximately 60 to 70% are individuals who are well enough to go home but are abandoned. And I don't know the exact amount of those who will be qualified as elderly. I'm saying all of this to say because our PS indicated that there are considerations as to how to approach this dementia issue. I'm tying both issues together. We don't know, have any studies that recognize what might be the factors that underlie this abandonment. Personally, there are issues with legacy and financial planning, etc. But significantly, dementia and the lack of capacity and cognitive capabilities are associated with some of these individuals that are abandoned. Now, What I'm wondering is if there is a consideration by the ministry for early screening, just like how we have screening for breast cancer, for ovarian cancers, or for prostate cancer, and other illnesses, cardiovascular illnesses, etc. Considering that we're having an aging population and the burden that this can be, is there a consideration to incorporate a screening process for dementia as you roll out this community intervention that you're speaking about? Primarily because it would be effective. And just to also add that dementia treatments, the very medications that are listed on the NHF, are most effective when they are administered in the early stages of dementia. So when the person actually starts to show the symptoms and you can clearly see that something is wrong, it's almost too late for those medications. So my question really is there that consideration of starting a screening process for dementia? Thank you.
Thank you. So the answer is yes, under consideration. There is the plan, a holistic plan for the elderly that the consultancy is wrapping up just about now, and this includes dementia.
But Dr. Webster-Carr, what I'm trying to emphasize, and the technical people that you may have on board, they will verify that it is when the dementia is in its early stages, which is usually before age 60. The most effective time is when you're just starting to have, or whatever at-risk factors you may have, if you have a history of cardiovascular diseases and etc., or other factors that are associated with dementia. So my advocacy is perhaps start the screening maybe at 50, because that is when it is most effective, or maybe later on, 50, 55. Your other experts might be able to guide. But usually, and unfortunately, when we wait until the symptoms are very blatant, it is too late. So
yes.
just given that consideration.
Agreed, Senator Longmore. And that's one of the reasons for the midlife study that is being done, because as you probably know, a lot of the dementia are probably vascular, cardiovascular. And when we saw how many were there, the prevalence, it's obvious that it's starting in midlife. And
yes.
The midlife study will start hopefully soon. And part of that study includes imaging that will reveal the MRIs, etc., will reveal the predisposition yes. And what sort of prevalence in the midlife. So it is, you're quite right, and we will look on it.
All right, thank you. Thank you very much. Thank you.
Senator Fraser-Binns.
Thank you, Chairman. Chairman, I want to go back to something that the PS said, because he shared an instance with us, which I'm quite sure is not the only one, but perhaps quite a few of those exist. And then I want to go back to something that we have spoken about in another place, and certainly since the commencement of our deliberations, and that is the Mental Health Act. Chairman, you know that I have said before that one of the things that we have to do is to consider the Mental Health Act and the changes that are needed, particularly in terms of those who can apply for guardianship. And you know, when I listen to the PS, I have the evidence that it is for this reason, Chair, why we have to ensure that there is an amendment to the Mental Health Act, because as it is now, the persons who can apply for guardianship is a very limited number of persons and categories of persons. And when we hear the instance shared by the PS, then it confirms that we have to widen that, and perhaps just like how in an estate, in an interstate matter, we have the bona vacancy and then the state comes in, perhaps we need to consider how we can give, even if not the state, but perhaps a body, coming out of our deliberations and then subsequent recommendation, that authority to step in, as would have been appropriate in the case shared by the PS, where this gentleman owns property. He went there, but they turned him back. This is his legal property, but he could not access it. And perhaps, Chairman, I want to actually use this as another opportunity to put on a record that we need to ensure that in our deliberations, the Mental Health Act comes under scrutiny and that recommendations are made for its amendment to deal not just with, but certainly situations as mentioned by the PS and other likely situations.
Yes, very well. Thank you, Senator Fraser-Bint.
And Chair, you know that that's always an advocacy of mine. So I underscore Senator Fraser-Bint's intervention. There are many applications here regarding the Mental Health Act and the care of the elderly that needs urgent attention. Thank you.
Thank you too. So part of what this committee is engaged in is a learning process, and for very many of those who have come to share with the committee, we have benefited a great deal, no less today. So while we have a charge to understand the circumstance, we also have a charge to propose a remedy. And I am throwing out for the team's consideration, when you have high numbers of abandoned persons, elderly persons in the hospital systems, you have, as came out of Senator Gale's interrogation, contact tracing, tracing at registration, but you have numbers where people are not answering it. How do those people who you're calling about this person engage in your registration system? Are they putting themselves forward as persons responsible for the elder person, or are they putting themselves forward as a contact to call?
They're putting themselves forward as a contact to call. Remember, healthcare is free. So they wouldn't expect to get a bill. And if that is the case, then nobody would, or very few people rather, would be prepared to put down their names as being responsible for the care of those individuals.
Well, it's a question, PS, that needs to be asked, not so much responsible for the bill because it's the public system, and we as a country carry that burden, but responsible in the sense of who is the person who stands for this elderly person. In other words, I am conceiving of, do we need to have something in our law that is a little bit more robust in terms of creating that a provision where we can assign that responsibility or we can enforce the person's assumption of that responsibility. Because if that were the case, then you have somebody that you can call. If they don't answer, then there needs to be an officer visiting them at their home and saying, look, you have your responsible senior citizen in the hospital system. Please go and get him, because otherwise the cost of having him there or her there is now going to be assigned to you by the state. Is that somewhere we go? Senator Gale?
If we are treating with this, let's call it a crisis of abandonment, and it's not about the retention only of the persons within the duty of care of the state, but the transference of that individual back to their homes is important. And if we are going to seek to mitigate against that level of abandonment, maybe we need to have certain scriptures that are rigorous in nature from the point of admission to the contact tracing, have it so rigorous in nature that it compels persons to respond. Maybe we just take it now that, John Brown brought the person in, and John Brown would have been the person. Let's say, for instance, somebody was knocked down on the street and somebody brought them in. So that's a John Brown who brought them in. No, that's not a relative. But at the point of the contact tracing, have it so rigorous in nature that we have concrete information in terms of the relatives. Because we have to take strong measures if we're going to mitigate against the level of abandonment. And it's not only the question of having the persons in the duty of care of the hospital, but they need to go back home. They came from a home, and they certainly need to go back to that home. And so we have to take strong measures, and maybe, Chair, we have to examine what kind of provisions in law that is going to aid to mitigate against these circumstances.
So, Chair, everyone that is admitted to a hospital, you have to name your next of kin. It must be there. Your next of kin must be named. What invariably happens a number of times is that I've seen instances where persons die in the hospital, the state have to bury them, and as CEO of KPH, what I used to instruct my people to do, rather than just call the undertaker and bury the body, they will get a pauper's grave. I would put notices in the paper. I don't know if they still do it. But I put notices in the paper to say this person was admitted into the KPH at this time. You know, the person unfortunately has passed. So anybody know of? And that is when sometimes relatives would come forward and would say, I did not know, I'm his daughter, I did not know that he was in the hospital all this time. You know, so we have a number of instances of those as well. But I agree with you, Senator Gale, we need to ensure that we put things in place that we can really get people to understand the nature. And we do have social workers in every hospital. We have them on the establishment in every hospital that actually go and investigate each of these cases.
Thank you. Senator Fraser-Binns, just before you come in, I've just been advised that there is another committee meeting at noon today. And so after Senator Fraser-Binns' question, I'm going to stop interrupting the team and allow them to finish their presentation, and then ask members if they could just note their questions, and we'll try and get them in at the end. Okay?
Thank you,
No,
Chair.
get the questions in at the end, yes.
Chair, I'm going to have to leave after this, but I wanted to just find out, because while listening to the PS, something occurred to me. And I wanted to find out, PS, if you have information in terms of, one, whether there are abandonments in private hospitals, and two, if so, what is the percentage? And I ask you that because in all our discussions, we have been talking about the public hospitals. So I'm not sure if it's just because there's a particular mindset amongst us mainly, or if it is that the data we have speaks primarily, speaks to the public health sector. And depending on the answer, Chair, then it will also guide us in terms of the recommendations we can make. So for example, and I'm preempting the answer from the PS, if it is that the data shows that abandonment takes place primarily in the public health sector, then it means, therefore, that our attention needs to go to why is it that there's abandonment in the public health sector and not in the private hospitals. And having ascertained that reason, perhaps that is where the intervention may come in. So, PS, if you have that data, I'd be grateful for you to share it. If not, you could send it to us at a time convenient when you and your team would have an opportunity to gather it. Thank you.
I do not have that data, but I would hazard a guess, because we do get referrals from private hospitals to public hospitals on a daily basis. So if a private hospital, for example, have a patient that they can't manage for whatever reason, they would refer them and send them to the public hospitals. The public hospitals can't turn away anybody. Doesn't matter what the situation is, the public hospitals can't turn away people.
And if I may follow, please, Chair. So PS, and it's not grilling you, but is it that a patient who has been abandoned in a private hospital, that the private hospital could easily transfer that patient to the public hospital, not because of the illness, but because of the abandonment? I'm just trying to understand based on your response.
They couldn't ethically transfer an abandoned patient to a public hospital. They would have to transfer them based on an health issue. So that person would have some health issue that the private hospital would refer to the public hospital.
So what you're saying, PS, is that if it happens, or when it happens, it's happening on the basis of a transfer due to the malady.
Issues, yes.
Okay.
Illness.
Yes.
Okay. And
It
do
could
you
be- it
and
could
do
be-
you
Sorry, it could
Go
be
ahead.
situations as money running out. We get a lot of patients from at Victoria Jubilee where the mothers run into problem, and they will tell you personally that the money run out and the private hospitals will send them down to Jubilee to have their baby.
Right.
Yeah.
Right.
Thank you, PS.
Thank you, Senator Fraser-Binns. I will allow the team to just complete.
Thank you very much. In the interest of time, we do have standards and regulation here. Dr. Sean Moncrief, he is the person responsible for the regulation of nursing homes and hospitals. He prepared a submission, and we'll give you 5 or 10 minutes, and then we'll ask Mr. Everton Anderson, who manages the National Health Fund, which plays a very, very critical role in supporting the elderly in this country based on the medication that they provide at pretty much little or no cost to persons like myself who can really afford it.
Thank you. Good morning, everyone. So I'm responding to 5 questions that were sent in. The first one, how are these private operations regulated? So the Ministry of Health and Wellness exercises its authority to regulate private healthcare institutions, including nursing homes pursuant to the Nursing Home Registration Act of 1934. And under this act, a nursing home is defined as any premises used or intended to be used for the reception of and provision of nursing care to persons suffering from sickness, injury, or infirmity. And the regulator framework operates on 2 different levels: registration and ongoing monitoring. So when somebody applies, if they intend to operate a nursing home, or they're currently doing so, they must apply to the Ministry of Health. An application is submitted, and they must demonstrate compliance with legal requirements that are established under the ministries, departments, and agencies. So we're looking at things like institutions like Companies Office of Jamaica, the local municipal corporation, local public health department, and the Jamaica Fire Brigade. And with respect to the staffing, the nursing and the doctors, the nurse must be registered with the Nursing Council of Jamaica, and the doctor must also be registered with the Medical Council of Jamaica. If it's an institution that's going to do things like diagnostic imaging, then they must have received approval from the Hazardous Substance Regulatory Authority. Now, with respect to monitoring, that is also done according to the Act. You have regular inspection that are done, and upon inspection, looking at things like whether or not the facility is maintaining its records properly, suitability of accommodation provided to the residents, and availability of adequate or competent staff. And of course, if approval is given for registration, then a certificate is issued, and it is valid for 2 years, and this certificate must be displayed. The second question, how many nursing homes are monitored by the ministry? As at April 2025, we have a total of 30 facilities that are registered under the Nursing Home Registration Act. It includes 4 private hospitals, 4 medical ambulatory surgery centers, and 22 long-term care that encompasses both nursing homes or what we call residential care home. And just to insert here, we have approximately 200 facilities operating across the island. Unfortunately, only 10% of them are really formally registered right now.
Yes. That really jumps out at me. What
I
is
expected
done,
it to.
Yes. What is done for these 200 that are operative but not registered? Because there must be a requirement for registration that you meet certain threshold or parameters. So what is done for these 200 now? Is it like you have the bar that says, I intend to apply for a spirit license?
Well, the inspectorate goes to these facilities and clearly go through. There's an extensive list that is done upon each inspection, and it outlines the areas that they have met, areas that are outstanding, the challenges that are observed, and they're given a time period within which to comply with these regulations. Unfortunately, many times upon return, a lot of these things have not been met. It's in trying to approach these issues, we're going to have to look at some multi-stakeholder meetings to really narrow in on how we deal with these facilities going forward.
I don't believe that some of them may really need assistance and support, whether guidance or directives to get them to elevate to that particular level. So are there mechanisms in place to lend that kind of support?
Well, we always try and share the necessary information and so on. But I must interject that although we use the term nursing home loosely, yes, some of them really don't fall under the bracket of nursing home. Some of them can be referred to really and truly as residential homes. You know, because
providing that support.
Yeah.
Okay. But those you are not concerned about.
Well, as one of the part of the plan for this fiscal year is to now look a little more deeper into these homes and see how best we can help them.
Right. As part of the registration process of a nursing home,
yes,
are they required in any way to verify to you that they have proper people working there? So, for example, not just a question of academic credentials, but whether or not a person may have a criminal record, may have been accused of any crimes against elderly persons, or in any way come into contact with the law. Are those things that you verify in inspection?
I know the list is quite extensive. I can get further details on the depth to which they go. But
would you provide us with
yes,
the criteria that they have to meet,
yes,
please? We would be grateful for that.
Sure.
Yes, thank you.
Maybe any further recommendations to increasing that level of threshold that you may have identified, because say years ago you would have had specifics, but times have changed, times have evolved. There might be the greater need for protection, and so we want to ensure that whatever provisions we are pursuing as a committee, would be in alignment with those recommendations.
Yes. Okay.
And I just want to say, for the benefit of the public, that the Nursing Home Registration Act is a 1934 law.
Yes.
I mean, it has been amended a couple of times, but very few times. So one of the things we want to be mindful of in this committee is the need to ensure that even if there is an existing law, that in the process of making proposals for a comprehensive law dealing with the elderly, that we're also updating, upgrading, and not repeating systems that are onerous, arduous, and archaic.
Yes.
But as Senator Gale said, looking at it with a modern eye and a prospective eye.
Yes.
Thank you. Go ahead.
Thank you for that. Question 3, how frequent inspections of private nursing homes are carried out? Is done 1 to 2 times per year, depending on the type of facility. For example, the smaller ones, like the nursing homes, make twice a year, and private hospitals once a year. So upon visiting these institutions, looking at document reviews, patient records, staff records, are they properly maintained, logs, safety logs for food, and so on. And of course, direct observations, walking through the facilities, issues to do with waste management, living accommodations, infection prevention, and of course, interviews are conducted with the staff members. Question 4. Yes, of course, a feedback. Question 4, the number of persons in these homes and gender breakdown. So approximately 22 registered long-term homes as the nursing. This is covering both the nursing and what we call residential care homes. We have a total bed count of around 423, total patient residents 313, males 136, females 177. And the final question, whether there are private facilities other than nursing homes that are monitored by the ministry. If yes, identify the types. And so we're looking at private hospitals, ambulatory surgery centers, long-term care facilities. And I think, and within the category of nursing homes, we classify as maternity home, convalescent homes, palliative care centers, and hospices. And that's the end of my presentation.
Is it Mr. Moncrief or Dr. Moncrief?
Dr. Moncrief.
Mr. Dr. Moncrief. Yes. Okay, I thought I had heard that. I apologize if I misspoke earlier.
That's all right.
Dr. Moncrief, is there the inspection system that the Ministry of Health carries out? Is that mandated by law? Is that part of your administrative management of your regulatory rule?
It's guided by the requirements of the Nursing Home Act.
Okay. Yes. And what happens when you don't? I mean, are there situations where you may not get to a nursing home in a year? What then happens in terms of the inspection obligation?
Well, the team sets out a schedule for each quarter, and they try to follow it as best as possible. If, for example, within a particular period, a plan has been realized, then as soon as possible, then they try and follow up. Or if even telephone conversations can be had at some point in time.
Right. And to the best of your knowledge, we are robustly monitoring and completing these inspections.
We try our best to do so. We have staff limitations, but we certainly try our best to do so.
What's the staff complement like?
We have around 6 inspectors. Six persons, yes.
Okay, very well. Thank you.
You're welcome.
Chair, just a quick question for Mr. Moncrief before proceeding. Just a quick one.
Go ahead, Senator Longmore.
Yeah. I was wondering, he listed the number of facilities. Does this include homeless shelters also? And does the standards and regulations apply likewise there?
My apologies. Start the initial section of the question. I missed that. Sorry.
Homeless shelters.
Yes.
They fall under this these standards and regulations too?
No, they don't. That falls on the local government.
That would be
so
local government and poor relief.
Yeah, understood. So my probably bigger question is the alignment and the synergy that needs to happen, perhaps. Just recognizing that.
Okay.
Thank you.
Thank you.
Senator Gill, do you have a question?
My questions are in relation to question 4 and the responses for the legislation. And I would have taken note of the mandatory reporting of elder abuse for both physical and mental, but who are we mandating? And the second one, I am happy that now I believe I have some support that the government could consider further increasing the statutory retirement age. I now have some support from the Ministry of Health, and I have it on record. The question is, what is the proposed age limit?
I defer that question.
I know you would. But in the interest of time.
Thank you, Chairman. We'll now hear from Mr. Everton Anderson, the CEO of the National Health Fund.
Yes, good morning, Chair and members again. There was a query, the take-up of NHF by the elderly and the JADEP program. So in terms of context, the NHF started in 2003 with the aim of providing support to several categories of patients, mainly those affected by the NCDs. And the fund has grown tremendously since.
NCDs being the non-communicable
diseases. We started out with 42,000 registrations after the first year of operation in 2004. To date, we have registered 801,000 Jamaicans on the program. Not all are active beneficiaries, though. We currently have about 352,000 active beneficiaries. And we've done quite a lot in terms of making the card registration easy and relatively uncomplicated. Initially, we would mail cards from our NHF head office all over the country. There are high rates of return, so that was not working out. Subsequently, we have established card centers in every single parish, and the waiting time to access a card, we've got it to around 15 to 20 minutes, including to add a new condition to your card. We currently have 332,000 seniors who have registered since inception on the JADEP card, and on the NHF card, 215,000. We're estimating that about 270,000 are active users of the card. That's the NHF and JADEP card combined, a total of 270,000. And this covers 24 chronic conditions, including hypertension, diabetes, cancers, among others. So we have seen a significant growth in enrollment. But if you look at the performance of the fund in relation to delivering benefits, we could not look on the NHF and JADEP card without looking at the other programs that provide pharmaceuticals to our population. Around about 2013, there was a cabinet decision that mandated NHF to take over the management of public sector pharmacies, and we commenced that process. At the time, there were several issues to do with staffing. Very few pharmacists were available, and the coverage in the public health system was very limited. We have subsequently improved our staffing population and put in a number of systems to improve access. And access to public health pharmacy services has grown significantly. In 2016, we're processing 1.28 million prescriptions. Last year, we processed 2.88 million prescriptions, an increase of 125%. We dispensed 5.9 million prescriptions in 2016. Last year, 9.5 million. In terms of number of persons who we see in our pharmacies, 403,000 in 2016, 749,000 last year. Of that 749,000, approximately 190,000 were over 60. So what it means is that between the NHF card, the JADEP card, and the free access at the 106 drug serve locations and partners, we are seeing good reach in terms of our elderly populations because the card is easy to get, and those who need it most at the right time will utilize it. So I think with the increase in the numbers for drug serve, some of those patients would not be in a rush to go and register. But what happens with those patients when they get what we call a catastrophic health expense, for example, they get a cancer that's covered, then they will move to get the NHF card to provide a greater support. Despite all of this, though, we still think that there's room to offer more for the elderly because it's at that age over 60, and it may be in line with what you're thinking, Senator Gale, that you may not be in employment, that some of the higher cost health expenditures may become relevant to you. And it's at that time that we may look at how we are able as a country to provide some broader support for the elderly. So I think we've done a reasonable job in terms of getting good access. Our fill rate in our pharmacies is 92%. So for the items on the list of drugs that we provide, we're filling 92% of that. And I think that's a significant improvement over the years, but we know that quite a bit of work still needs to be done to enable ease of access and ensure that the elderly enjoy the best possible health care. Thank you.
I just want to ask, because I think it's a well-efficient system, but you made reference to cards being registered but not active. In other words, persons would have received a card but not utilizing the card. And the greater proportion of those utilizing the card would have been the elderly. Right. Because I have my card and I use it. But the question is now the promotion of the use of the card. And I would have suggested that there needs to be a promotion in the workplace to support and supplement. If you already have a health card, you have your NHF to utilize. What is the extent of promotion in those areas that might be deep rural or underserved?
Yes, we have used various mechanisms to promote the use of the card. Apart from traditional media, we actually are in every parish almost every month through partnerships with the Ministry of Health, through the Know Your Numbers, our own health fairs. We probably do a few hundred health fairs every year in partnerships with other agencies, the Jamaica Cancer Society, Diabetes Association, and churches, faith-based.
Right.
And at all of those events, we do promotion. But I think the biggest thing we've done is have the card being ready to use and ready to access in every parish. So in every single parish, there's a card center where you can print your card, you get it within 15 to 20 minutes, and you can use it at the same time. But we'll continue the promotion, but I think one of the things, Senator, that I pointed out earlier, in our public health system, there is no cost at all for drugs. So with the NHF, there is a copay. So the average subsidy rate is around 50%. So if your drug costs $4,000, you're likely to pay $2,000. For $2,000, pay $1,000. In the drug serve locations in the public facilities, there is no charge. So even if you have a card, you may become inactive because you access, say, at a KPH or a Cornwall, you move to the pharmacy, you get your drugs, and you're out. So I think that's one of the factors.
How does that work now with sustainability of the fund, given the intensity of the growth in the elderly population on the one hand, and evolving with, cost of living and inflation, and maybe...
Senator Gale, let me jump in front of that question and ask the CEO to just explain to us how the NHF is funded and answer your question right on the back of that.
Right.
All right, so the NHF is funded from three major sources for the NHF, for the benefit side, which is the NHF and JADEP card, a portion of the tobacco taxation, a portion of NIS revenue, and a portion of the special consumption tax. And those have been the traditional funding sources from day one. For the other side, which is the drug serve side, that was a cabinet decision requiring us and mandating us to take over those. So that is funded from the drug budget provided by the Ministry of Health and Finance.
There's a new tobacco legislation coming. We have to look to ensure that there's a security of this support maintained in that legislation. Yes. Thank you, Chair.
I don't know if that is the intent of that legislation, but I agree with you. Mr. Anderson, could you opine a little bit about the NHF Act? What do you see, if any, are the limitations of that act in terms of how you have done your work? Where have you met the hurdles from the legislation that supports you?
I think Senator Gale mentioned one word, sustainability. The Act has specified revenue. I'm of the view that as a country, one of the biggest investments we can make is in healthcare. So maybe the Act now needs to look at what other sources of revenue could be put in the Act to make the NHF more sustainable and better able to provide long-term benefits for an aging population. I think that's going to be very, very, very important because just in discussing our appearance here, we're looking at some figures and we're seeing, while we're averaging, say, 13 or say 20,000 for hypertensive patients, we're seeing some cancer patients where we have to support up to $2 million. So I think over the coming years, we're going to need greater revenue, and we need to look to see how we can amend the Act to get some other sources of revenue to make it a broader program of health financing. I'll need to check.
I think Senator Longmore had a question.
Thank you so much. Hi, Mr. Anderson. Very happy to be engaging you here. And as always, I'm giving you thanks for all your effort at the Ministry of Health. Two quick questions, and just kind of one of them is a little bit out of the box, yes. But one of the challenges practically that happens with our clients, and not just the elderly, but persons who generally benefit from the NHF, what we see is a particular drug or treatment or whatever provision is made on the NHF at a particular cost initially. And then once the product is listed on the NHF, the price skyrockets. So unfortunately, there are circumstances where the benefit that, or the level of benefit that could be provided is actually shortchanged or limited based on what is the now available, or the repricing of some of these pharmaceuticals. Is there any effort that we can have to ensure that the citizens are getting the maximum benefit from the NHF in terms of a fixation or a regulation as to the prices that they face, even with the NHF benefit? That's one question. I don't know if I can go with the other one now.
Yeah, you can.
Go ahead, Senator
Okay.
Longmore. Make it a little bit more succinct, though, because we have a time constraint.
So the other question is there any consideration for non-pharmaceutical provisions from the NHF? So we're finding more and more that there are a lot of nutraceuticals, there are a lot of other as I said, pharmaceutical approaches that can be beneficial. Is there any consideration for the NHF to include these provisions too? Thank you.
All right. Thank you, Senator. Two good questions. Last one about other items, I think I can take first. Yes, there have been discussions, but I'll be guided by Dr. Webster-Carr and the team. And certainly we have seen companies submit for their items to be considered under NHF. And some of these are not traditional prescription items, but they have presented evidence that these items can help in making patients get better. So we definitely will look at that. In relation to the prices, I think it's something that we continue to discuss. In fact, we have an entire team that's set up internally to look at the environmental conditions surrounding drug prices globally and monitoring. And one of the things we discussed recently is looking at legislation, Chair, around managing the cost of drugs, because globally drug prices continue to soar. And in the U.S., you have the U.S. Inflation Reduction Act that looks specifically at drug prices. I think it's something that we really need to consider in Jamaica, look at an end-to-end approach in terms of managing prices, not only from the distributor end, but from imports, from all the charges that may apply to pharmaceuticals. Because if we're not careful, it's affordable today and not affordable tomorrow. Thanks.
Thank you very much. I want to, it is 11:57. P.S. With Mr. Anderson's presentation, would that conclude your submission?
Yes, unless. Thank you, Chair. Unless there are other questions for us, but yes.
Well, I want to do a little round robin in terms of I want to go back to Dr. Moncrief very quickly in terms of the Nursing Homes and Registration Act. Can you answer the same question I posed to Mr. Anderson in relation to, in terms of how your work is operationalized? What are you experiencing as the limitations of that act, the areas that there are gaps, and what would you suggest to us are your thoughts on fixing that?
Thank you. With respect to the Act, well, I think the Act certainly does need some revision from 1934, as was mentioned before. I think the specific team associated with standards and regulations, I think sometimes they feel that they don't have much teeth. Mm-hmm. And I think that is an area that I think we could improve on, so we can they can carry out their duties more efficiently. So that's one of the areas that the team has been speaking about a lot. And this doesn't have to do with the Act, but in terms of increasing our human resource is another important section. But of course, as we continue, we are trying to put together multifaceted team from in the fire department, the local government, public health area to come together to discuss exactly how we can move forward as we try to take care of some of these unregistered areas. You know, how can we encourage them to comply as best as possible?
What's the penalty under the Act for not registering? Do you recall?
I think it's a matter of just...
it's a fine?
I'll have to look into that. I don't remember out of head.
I'd be curious to know that. And I hear you on the question of enforcement. Just quickly, is part of what your team experiences, part of what your team is experiencing, does it include entering on the premises of a quote-unquote nursing home, and being barred from entry? Do they experience those things?
I haven't heard of any such.
Okay. Thank you. Senator Gill.
It's a question of, you asked for a strengthening in the legislation in terms of the operational teeth. I would certainly like to have what those recommendations are, because it would tell us where the impediments lies in those persons who are regulators and how they can operate. And the second thing is where you have the deficiency in the manpower resources. What are those critical areas that needs to be filled or expanded?
Okay, thank you.
Yes, thank you very much. P.S. I'm going to ask your team to just do a little bit of homework for us that you can submit to us at a later date. And that is in relation to the question that Senator Gale asked, the questions that were posed. And the clerk will just write to remind you and to summarize them. But also just to opine the question I asked in regards to the acts that are currently under your portfolio, what those gaps are. If you could just set those out to us, and what your concerns are or recommendations are in relation to how we fill those gaps and how we mitigate against the deficiencies that they have. I want to thank the team of the Ministry of Health and Wellness so very, very much. I learned so much today, and this has been very, very, very useful. So thank you for your time, thank you for your preparation, and thank you for answering our many questions. Thank you to my colleagues online, and Senator Gale, ever faithful to me in the chamber. Thank you so very much. I appreciate it. Parliamentary team, as always, and my ever hard-working committee clerk, Mrs. Beckford. Couldn't do this without her. Thank you all so much.
Thank
Senator Gale, would you move to adjourn us, please? Thank you. Senator Longmore?
Seconded. Thank you, team. Thank you.
Thank you. This meeting is adjourned.
Vomiting, severe abdominal pain, bleeding under the skin, feeling very weak, or getting confused, to seek immediate attention. Let us work together to protect ourselves against dengue.
Denise Williams here, inviting you to join us on Financially Focused, the ultimate destination for go-getters who are ready to take the step